Well, morning to everybody, and I'm a dermatologist, but in this setting I'm actually the student, and you certainly the teachers. And we've come here to learn from you, and as you've heard, in a lifetime perhaps a dermatologist sees one or two families. We have the opportunity to see a huge spectrum of patients here, and we learn every time from all of you. So that's our purpose here, to learn from you and to tell you a little bit about the condition that we actually know. I work at the University of Saskatchewan. I'm the head of the Division of Dermatology there. And for those of you who don't know where Saskatchewan is, I thought I'd put up this little picture. So it's in the middle of Canada, and Saskatoon's sort of in the lower end of it. And it's a reasonable sized city. It sits on a very large river, the Saskatchewan River, and we have a very nice university, beautiful campus, stone-walled buildings, and we have approximately 25,000 students. We have medical school, agricultural college, dental school, almost every faculty that you have in major universities. And that's the university hospital that I work in. It's the Royal University Hospital. This is the old part of the hospital, the major hospitals at the back. This is a major tertiary hospital. We get the referrals from the entire province. So I thought we'd just start by asking, well, what do these words mean? Pachyonychia Congenita. And I think that's a good start to understand what's happening. So the first word, Pachyonychia, well, pachy is a Greek word which means thick. So obviously something's thick. Pachyderm, of course, means thick skin. And pachyderms, you may know, are this group of animals that have got thick skin, and these are the elephants and animals in that sort of family. Onycho has something to do with nails. When you ever see onycho, it's got something to do with nails. So onychomycosis is a fungal infection of nails. Onychia is really an inflammation of nails. Congenita just means present at birth. And was this true for your PC? Could we have a show of hands? How many of you actually were diagnosed at birth or presented at birth? So a fair number. Now, who on earth gave this condition this name? And that's interesting to go back and have a look. And these are the two guys responsible. So this is Joseph Yoderson and Felix Lewandowski, and they were in fact dermatologists working in Switzerland, in Bern, and they published a paper in 1906 describing this condition. And they called it Pachyonychia Congenita, and for abbreviation it's nice to say PC. They also came up with an alternative naming for this disease, and they actually focused on the nails as the most important clinical thing, but they weren't bluffed by it. They knew there were lots of other things happening. And the other name was keratosis disseminata circumscripta, tylomata, and keratosis linguae. So that means these tiny little warty things that some of the patients get on their skin, the thickened calluses, and of course the changes we see in the tongue. That's a bit of a mouthful to call a disease, so even to abbreviate it would be, quite a thing. So I think we'll stick with PC. Now their case was rather interesting. This was a 15-year-old girl. She had a brother, and the brother was 4 and also affected, so they knew immediately that this was a familial and inherited condition. And this little girl had thickened nails from birth. The nails were described as being hard, narrow, smooth, shiny, with the tips being greyish in colour. In addition, these callus-like lesions were noted on the palms and soles, and blistering was also noted by these early dermatologists. as were the white patches on the tongue. They weren't the first really to describe this condition, because there were two previous papers mostly concentrating on the nails, but these are the two that really have had their names stuck to the disease. Now, what is PC to a dermatologist? What do we actually see and look for in patients? What gives us the clue that you have PC? Obviously the nails. The nails are sort of central to this. These nails are thickened and often very curved. But as you've heard, the nails are not the same in every PC family. So some families have got different looking nails, and here we have some real tubular looking nails. And others have nails that appear to be fairly normal when they start and then degenerate. And this is one that's sort of in between. These are all from true PC patients. The calluses, of course, you're all aware of. These occur on the friction areas, the areas where you weight bear. And this patient obviously has got quite flat feet and the weight bears across the entire sole of her foot. Here's somebody who really works the feet hard, and you can see the massive thickening that we see on the soles of this patient's feet. The hands, well, the calluses you get on your hands really depends on how much work you're doing with your hands. So the more you work them, the more callous they become. So here we have somebody who's got quite discrete calluses, and here we have a guy who does a lot of manual work and much more diffuse callousing of his hands. Can you see these pictures, or should we turn the lights down a little bit? You can see them all right. And of course you all know the tongue. Again, areas of friction that seem to bring this out. And then many patients have these funny little things. These are little warty-like growths that we see on the knees, the elbows, and sometimes also around the waistband or on the trunk. And then some patients, and some of you here, have these large cysts, and some have only a few, and others have really a large number of these cystic lesions. We've also seen another phenomenon, which is we just put in the literature, and this is where we seem to see the PC extending onto the surface of the foot, the top of the foot. Have any of you ever seen this in yourselves? I'd be interested to see a show of hands if you've ever noticed your PC getting on the top of your foot. We've got two in the audience. Okay, that's interesting. This patient obviously has it quite severely. It's quite well demarcated. You can see there's an edge down here and an edge at the top. So quite an interesting additional phenomenon that we see. What is PC to the scientist? Well, they like getting close to things. And so this is a part of our skin. This is known as the epidermis. And this is where your PC really takes place. And this is normal skin, relatively normal skin. And you can see this is the skin is always in the process of renewal. The cells are growing up to form this dead layer on the outside, which is the barrier. This is what protects us, that seals us, and that's really an important layer. If we look at this epithelium, we see it's made up of these cells. And in PC, or in normal people, if we look at a cell and we stain it specifically for a special fiber known as keratin, this is what it looks like, this nice scaffolding around the nucleus of the cell. And if you can imagine that that is a little house. In a house we obviously need structures, we need things to take the pressure, to keep the structure in place, and these beams give the house support, in the same way as keratin gives it cell support. And if you have support structures that are not great, then obviously your cell or your house is very easily damaged, falls apart, and is quite fragile. And that's really what happens in PC2. This is normal skin, normal keratin, the nice structural form of it. And in PC, you can see these fibers are really not formed. There's no real structure, no supporting structure for this cell. So these cells have this defective supporting beam structure. They become very fragile. They're very easily damaged, friction, pressure. And the skin responds to this by producing more and more of these cells. If they're going to be wiped out, we have got to produce lots of them. And of course, that leads to thickening of the skin, and this can be quite obvious. Here we have skin from the sole of the foot. This is the normal epidermis. But look at this. This is that callus you've got on the outside. If you look at normal skin, this is what the outer dead layer looks like, just this thin little layer. So this is really quite considerable thickening. Your skin has tried to put a coat of armor on your skin. And of course, not only for him, but for her as well. So, and here we can see this real coat of armor that's developed to try and protect the sole of the foot because of these fragile cells. What is PC to the geneticist? And I'm going to leave this to Francis to talk about, because this is really where it all starts. I think most importantly, what is PC to the PC patient? And I think number one is pain. Everybody agree with this? Hands up. Pain. Decreased mobility. Agreed? People are not able to play sports as other people can. They're not able to do manual labor and do these sort of jobs that require mobility and walking, and not able to stand for long periods. They have to have a chair at their workplace. Not able to do fine work with their fingernails. They find that time consuming and that time taken just to groove the nails is quite significant. Patients find that this disease is quite embarrassing. They often hide their nails. And of course, in some patients this may be quite depressing and can influence the quality of their life quite considerably. We're doing a little quality of life project specifically designed for PC patients, and I'd be very happy if you'd try and complete the form so that we can actually get a good idea of how your quality of life is affected. And if there are questions there that you think we should add, things that really affect your life, please let me know, because we would love to include anything that you feel makes a difference in your quality of life. We must be able to try and measure that and capture that. What is PC for the PC project? I think this is to pursue a cure for PC, or at the very least, to have treatments that help. And I thank you very much for your attention.